Bismillahirrahmanirrahim. So up till now we have covered almost the physiology. So now we are coming back to the pathophysiology part. So glucocorticoid and the Cushing syndrome. So Cushing syndrome is actually the hypersecretion of your glucocorticoid, or you can say So Cushing syndrome and Cushing disease. What is the difference between Cushing syndrome and Cushing disease?
Cushing disease is the edema of the pituitary.
Yes.
The pituitary gland is called Cushing disease.
And what is Cushing syndrome?
Hypersecretion of anything from the pituitary is called syndrome.
So actually, Cushing syndrome mean our hypersecretion of glucocorticoid. So if the reason is the adenoma of your pituitary, so it is Cushing disease. So if the reason for the hypersecretion of Cushing syndrome is the adenoma of pituitary, or you can say the other adenoma, for example, cancer in the small lung cancer type. So anything which increase the ACTH secretion which is stimulatory for the adrenal cortex. When there is a hypersecretion of ACTH, there is hypersecretion of your cortisol or glucocorticoid. So if the reason is pituitary, it's Cushing disease. If the reason is other than the pituitary, small lung cancer type, so we can say these are Cushing syndrome, where adenoma of your pituitary or the small lung cancer is involved. So causes. So if the hyper increase of the cortisol, if for example someone is taking most common use for exogenous, for example taking the cortisol, in this case they decrease the ACTH, because when there is high cortisol, it will send negative feedback. So in response, what will happen? Our ACTH level go down. So this may lead to, when there is a low ACTH, our adrenal gland is not taking the ACTH supply. In result, what will happen? There will be atrophy of your adrenal gland, because no stimulation is coming. Our adrenal stop their function. When there's stoppage of function, there will be the atrophy. So because ACTH supplying both sides, our left and right suprarenal gland, so bilateral adrenal atrophy in this case may occur. Okay. So another condition which is endogenous corticosteroid, it's increased endogenously inside the adrenal gland. So in this case, there may be a primary condition and the secondary. What is difference between the primary and secondary? So this question is really tested in your exam especially. So primary there is problem in the gland itself, for the adrenal gland. Secondary there is problem in their stimulatory pathway, a problem may be in the pituitary or in the hypothalamus. So when there primary there is the cancer in the adrenal gland. So when there is tumor in adrenal gland, their secretion increase. So this is primary. So if there is adrenal gland is okay, there is no problem in the adrenal gland. Problem is in the pituitary. There is a tumor in the, for example, in case of tumor. So when the tumor increase in ACTH, when there is high ACTH, it will affect the adrenal gland. So in response of tumor of pituitary or hypothalamus problem, so this is secondary type. There is problem in the stimulation pathway. Okay. So primary itself gland, and the secondary problem in the control system. So primary adenoma or hyperplasia or carcinoma will increase the endogenous corticosteroid and which will decrease the ACTH with the atrophy of uninvolved adrenal gland. So ACTH level go down because by the feedback pathway. Okay, and it's ACTH independent, because problem is in the gland. So no problem with the ACTH secretion. So we can say it's ACTH independent pathway. And if you look at secondary hypersecretion of ACTH, so result in bilateral adrenal hyperplasia and ACTH dependent, because high secretion of ACTH. So it's two main categories. One we have discussed, maybe hyper secretion of ACTH. What is origin of the ACTH? Mean if there is a problem in the adrenal gland, in the pituitary gland, this ACTH coming from the adrenal, the pituitary mean adenoma of pituitary, and which we call them the Cushing disease. Or other sources, any other cancer in the body also can secrete the ACTH. For example, small lung cancer. So we divide into two categories: Cushing disease or ectopic ACTH syndrome. So Cushing disease causes pituitary adenoma, usually in the macroadenoma, which is less than the 1 centimeter diameter. So, and most common pathological cause of Cushing syndrome. So we can say Cushing disease one of cause of Cushing syndrome. Okay, other cause may be the small lung carcinoma of lung or bronchial carcinoma. So cancer in other organ can secrete the ACTH. So this ACTH can affect the secretion of glucocorticoid. Okay, so this is Cushing syndrome. For finding, I just recall the function of big fever. A mean appetite, B mean blood pressure, insulin resistance, gluconeogenesis. So these functions are going to increase, and fibroblast activity is going to decrease, immune response are going to decrease, and your bone formation going to decrease. So there is a hyper secretion, mean they have starving, or mean they have their appetite level will be high. If you look at the blood pressure, so they have hypertensive type. And if you look at the insulinogenic or diabetes or gluconeogenesis, so mean their hyperglycemic condition. And if lipolysis mean lipolysis is more, mean there will be fat deposition. For example, they have moon face because of fat deposition. So they have fat deposition over the abdominal level. So buffalo bump on here. So these kind of condition could be, and because their function is proteolysis, so they may have muscle atrophy, mean because protein is going to destroy. So these kind of condition, and they are more sensitive toward the immunity problem because immunosuppressive function, and they have osteoporosis type of function. Okay, so just recall, so second, at the second you will see cetraya and easy bruising and decreased wound healing and thinning of skin. And if you look at osteoporosis, immunosuppressive function, and hypertension, because one of function is blood pressure, so increased sodium reabsorption in kidney and increased vascular reactivity, and they have hypokalemia type and alcohol because they have partial mineralocorticoid function. Little bit, because one of function is blood pressure, so which is also mineralocorticoid function. So they do some mineralocorticoid function. So finding may be hypokalemic alkalosis type, and if cortisol is high, hypokalemia is mostly uncommon, but maybe some hyperglycemic, peripheral insulin resistance, diabetogenic non-insulin, such kind of condition. Polyuria, because hyperglycemia means there is a high glucose level. So diabetes type, so they have urine secretion is increased as compared to normal life. Okay, so polyuria type because of hyperglycemia and increased free water balance. So, and if you look at the fat deposition, so they have moon face type and truncal obesity. So they because of fat deposition, and buffalo have hump at here, so and thin extremities, so the limbs are thin and increase abdominal fat, so their abdominal fat or truncal fat is going to increase. Just recall your function, you can easily understand it. So, and protein metabolism is disturbed, mean muscle atrophy or myopathy type. So progressive painless muscle weakness predominantly involving in the proximal muscles, and it is due to direct catabolic effect of your this cortisol on the skeletal muscle leading to muscle atrophy. And if you look at because when there is a cortisol level high, so their cool secretion, which is the lower layer, is the reticular, where androgen secretion increase. So their condition may be menstrual disorder mean amenorrhea, no period is coming, and hirsutis mean their libido level is increased, mean their interest for the other gender is increased. So co-secretion of adrenal androgen with the cortisol. In case of men, their erectile dysfunction. Okay, so these could be the finding of your and if there congenital disturbance, mean decreased concentration to the psychosis. So these are features, you can say moon face, and their muscle is wasted, and you can see striae on the skin, and fat deposition is in the truncal and the abdominal part, and weak the extremities, and their muscle is atrophied. And so these condition and buffalo hump at here, and supraclavicular fat pads are present here, central obesity. So these are findings you can identify. This is your Cushing syndrome type. Okay. So we have covered the Cushing syndrome. So because in the physiology there are layers of concept. When you understand the first layer, then you move to next. First you understand the function, then you move toward the pathology, then you move to understand the test, how they are tested. So we are actually if you look recall the secretion of your cortisol. In the night time, midnight, there is low. In the morning time, there is high. So in Cushing syndrome, so we test for this. Actually, we take 24-hour urine test because there is a difference in the secretion of the cortisol throughout the 24 hours. So we'll take the late night salivary cortisol test and the separation test, dexamethasone. Dexamethasone is actually cortisol type. So we need to differentiate either it's a primary type or it's a secondary type. We know better primary is ACTH independent. Their problem is with the adrenal, while the other one was the ACTH dependent. So when we give this one, so mean when the extra cortisol come, exogenously cortisol come, they will do what? Feedback, send feedback, mean our ACTH level go down. By giving the dexamethasone, we decrease the ACTH secretion. So we see, for example, we measure the serum ACTH. If we see that suppressed, mean problem is in the ACTH independent Cushing syndrome. Mean it's a primary type, secondary. If independent, mean it's primary type. While if it elevated, because the problem is in the pituitary already, so ACTH remain high. So in this condition, our ACTH dependent condition mean elevated. So if by giving dexamethasone, if you see suppressed, mean it's primary. If still elevated ACTH level, so we can say it's a secondary. So it's primary type, it's secondary. So for this, because it's primary, we can go to the CT scan of adrenal gland, because problem is the adrenal gland. So exogenous glucocorticoid adrenal tumor is problem. So we can take the CT scan of adrenal, no need to go to the pituitary. Problem is the primary. So for the secondary, so then we differentiate either it's a Cushing disease or the ectopic, lung cancer type. So for this we give the increase the dexamethasone dose. So when they increase, actually what will happen? So if no separation, mean when we increase the normally it should be decreased because by the feedback. But if the source is other lung cancer, so lung cancer is not inhibited by the cortisol because there is no feedback is going to the lung cancer. So in this case, no separation. So mean elevated. So we can say this is ectopic ACTH dependent. So if the separation occur, mean it's Cushing disease. So for other case, if we stimulate the CRH, we will stimulate the ACTH. So when they stimulate the ACTH, mean our ACTH and cortisol level go up, mean it's Cushing disease. So if not increasing because their source is ectopic lung cancer. So that's why for these conditions, for example, ectopic, we take the CT scan of the chest, abdomen to check the cancer of lung cancer type or pelvis. So for Cushing disease, we go to the MRI of pituitary. So this is one test. So in this way we can differentiate primary, secondary. In secondary we can differentiate it's ectopic type or Cushing type by two tests. So Metyrapone, so it's also a stimulatory type test. So it actually inhibits your one of enzyme which was our synthesis pathway. So I'm not going to my detail. Just look at recall this pathway. This was our aldosterone synthesis pathway. This was our cortisol synthesis pathway. This was the androgen. So glucocorticoid, mineralocorticoid, glucocorticoid, androgen. So actually this drug which is mentioned, Metyrapone, it's actually going to inhibit alanine beta hydroxylase. So this step. So when they inhibit, so what will happen? So this pathway stop, mean no cortisol synthesis occur. So eventually what will happen? Our alanine dog will increase this because this is precursor. So but the cortisol is the actual hormone. This is not actual glucocorticoid. So this can send feedback to our pituitary. So when there is higher cortisol, ACTH will decrease in the feedback. But in this case, 11 dog do not send a feedback. So by this test, we can identify the Cushing syndrome by this because if a cortisol problem. Okay, so same thing is actually mentioned here in. So it's stop the 11 beta hydroxylase, so which is responsible for the conversion of into cortisol. So the Metyrapone administration, so serum cortisol are reduced, stimulating the ACTH, because when cortisol down, ACTH go up. Our dog cannot send feedback. So and in this setting, the high ACTH stimulates the adrenal gland to produce more dog. So and since cortisol cannot produce due to inhibition of 11 beta hydroxylase, unlike cortisol, we are ready when dog cannot send feedback to the pituitary. So production 11 dog multiple and measurable. So we can see these their metabolites, their breakdown products in the urine. So because there is high level. So if the HPA mean hypothalamic pituitary axis is normal. So by giving this administration, our cortisol level, the dog will increase. So because ACTH production also increase, not go decrease because cortisol is not synthesized, which is not going sending feedback. So in primary adrenal insufficiency, increase ACTH, but level does not increase because adrenal problem. So adrenal cannot synthesize any hormone. So we can define the adrenal insufficiency cases, primary mean Addison disease, for example. So because in the adrenal is damaged, so they are not synthesizing any hormone, mean they do not synthesize this 11 dog. So but our ACTH will remain high because cortisol is low in the blood level. So adrenal gland have failed to produce the dog. So in secondary adrenal let's see before that adrenal corticoid, we have covered almost the glucocorticoid disorder. Now coming to the mineralocorticoid disorder. So this pathway, I think this step I already covered. We have seen that when the cortisol high, they can bind with the aldosterone receptor. But kidney has a hormone which converts the cortisol into cortisone. So cortisol cannot bind with this. So there is no problem with the high cortisol. Do not inhibit the aldosterone function. So they allow the function of aldosterone. This is actually theoretical. So coming to the Conn syndrome, or you can say aldosterone. One is primary, one is the secondary. So primary hyperaldosteronism, we call them Conn syndrome, and secondary we call them the hyperaldosteronism. So primary means associated with the gland.
Gland.
And secondary main problem is the pituitary axis, hypothalamus pituitary axis. So in this case, the bilateral adrenal hyperplasia in 60% cases, or you can say adenoma. So when there is a tumor, so they increase their secretion of aldosterone. So we named them the Conn syndrome. So and this lead to actually resistant to hypertension because the aldosterone is associated with your blood pressure. So and autonomous overproduction of aldosterone despite high pressure with a low renal. So because when there is low pressure, we need aldosterone function. But in this case, blood pressure is high, also aldosterone is high because of tumor. So instead of renin is not sending a signal, but because aldosterone synthesis occurs when renin comes. But in this case, there is a tumor. There is no need to come regulatory system which will send signal to secrete the aldosterone. But because this is a problem, pathological condition. So instead of high pressure and low renin, it's continuous secreting. So it's a rarely malignant type. So our condition will be when there is high, mean what will happen? Aldosterone is high. What will happen? Our blood pressure will be increased. Our hypernatremia type, hypokalemia, or alkalosis type. So these conditions are our finding. So hypokalemia and metabolic alkalosis and the natremia, hypernatremia, you can say low potassium level either found on. So you cannot say if there is hypokalemia, you can say it's Addison Conn syndrome, because sometimes in routine lab testing, so because of symptom muscular weakness or paresthesis, so hypokalemia can be occur. Any other source can be occur. So if all these findings are present, you can say it's a Conn syndrome. So if you look at the secondary type, so it's due to our renin-angiotensin. So sorry, we have missed the concept. In the primary problem is the adrenal. Secondary means the control system. For the aldosterone, control system is not ACTH. Control system is renin-angiotensin aldosterone. So there is overactivity of renin-angiotensin aldosterone in the secondary type. So due to kidney perception of low intravascular volume, so renin-angiotensin system is overactive. So in the patient with the renovascular mean renal type, so the blood vessels of your kidney, so they feel the hypertension and the juxtamedullary cell tumor, so or edema. So they may cause cirrhosis, heart failure, nephrotic syndrome. So these conditions can lead to secondary hyperaldosteronism, modest to highly elevated renin. So when because there is tumor, here renin will be increased. In that condition, ACTH is going to increase. So depending upon the condition, so hypokalemia and the metabolic alkalosis will occur because there is a hypersecretion of aldosterone. So in this condition, you do not find the hypernatremia or edema. Why? The question is why there is no edema occurring in this condition. Because you know when there is high aldosterone function or productive system active, which is aldosterone escape system, so they do not allow the edema, or so they release they excrete the sodium. So in this way, we are not excreting, not find the edema in this patient because of aldosterone escape phenomena. So only mild increase in the exertion can occur, but our by this mechanism we save the edema. No edema will be found. So easier way to understand the differentiate the primary and secondary. In the secondary, our renin is high because the problem with the renin-angiotensin system. In the primary, problem with the adrenal gland itself. So in the primary, renin level is low because due to feedback. But in this condition, secondary problem is the renin system, so overactivity, so renin will be high. So if low renin, we can say it's primary. It's high renin, we can say it's secondary. Okay. So these are actually summary of all the points. Etiology, we have covered this, so you can read. So renin are typically very low due to hypervolemia, and so hypertension, mild hypernatremia, hypokalemia, metabolic suppressed plasma. Renin, so weakness and paresis are highly suggestive of the primary mineralocorticoid excess, or you can say Conn syndrome. So the question is why is normal sodium and is normal potassium is low, bicarbonate is sodium is normal because of our aldosterone escape system. So, but these conditions, hypokalemia occur because of high aldosterone and the bicarbonates are also high. So, the treatment we simply go to the surgery to remove the tumor, or you can give the spironolactone, potassium sparing diuretics that works by acting as an aldosterone antagonist. So, it's an antagonist. So, because we stop the function of aldosterone. So, now we have covered the hypersecretion of the glucocorticoid and covered the hypersecretion of aldosterone. So, now coming to the almost last segment, we got insufficiency, adrenal insufficiency, no secretion is occurring. So, primary adrenal insufficiency and secondary. Primary mean problem with the adrenal. Secondary mean their problem with the control system. So mean ACTH, the pituitary hypothalamus excess problem. So in the primary, what will happen? Adrenal glands function go down. So in which what will happen? Our all secretion go down, cortisol, aldosterone, androgen go down. In this condition is called actually Addison disease. Okay, Addison disease mean problem is adenoma. For the chronic primary adrenal insufficiency caused by the adrenal atrophy or destruction. So, most commonly due to autoimmune adrenalitis, so autoimmune diseases which destroy our adrenal gland. So, in the developing world, you can say in the European world and Western world, so autoimmune disorder is most common. In this region, for example, Asian countries, so our developing world, the tuberculosis is the most common cause of the primary adrenal insufficiency. Okay. So findings because there is low aldosterone mean hypotension condition will occur, and hyperkalemia will be occur, and the metabolic acidosis will occur due to deficiency of this, and skin mucosal hyperpigmentation. Maybe it's like not but you need to recall this concept because we know better the ACTH and the MSH, the melanin. Melanin, which is their origin or precursor is in POMC. So, because of CRH when come, they stimulate the POMC, so they secrete both things, ACTH and the MSH. ACTH come here and stimulate the adrenal, but MSH do what? Melanin, they cause a hyperpigmentation on the skin. Okay, so in this patient, because there is a deficiency, so feedback our ACTH go up. When ACTH go up, MSH also go up. So because of increase of both things, so MSH increase, so our skin mucosal hyperpigmentation will occur. So in secondary type, what you are going to see, your pituitary ACTH secretion mean. And tertiary, you can say go to the hypothalamus. So mean hypothalamus a problem. Secondary, we can consider the pituitary, and tertiary we can consider the higher level, which is tertiary. Mean the hypothalamus CRH secretion is decreased. Or other source, if you use someone using exogenous steroid use, or so as the most common use for because to maintain the stress, they use the cortisol exogenously. But when they withdraw this, what will happen? they decrease the secretion. So because in the feedback, ACTH level is low. So in these patients, due to low ACTH, mean low secretion of cortisol, so these hormones, so there may be a problem in these exogenous steroid use, and they abrupt withdraw. Okay, so and most commonly due to abrupt cessation of chronic steroid therapy. So when they stop this, so HPA due to HPA separation, secondary can occur. So our finding will be hypotension and the no hyperkalemia. Why? Because you know better, ACTH is no concern with the aldosterone. They are concerned with the our lower two layers, the fasciculator and the reticular. The aldosterone controlled by the renin. So when their ACTH low or high, they are not affecting much our aldosterone. So no hyperkalemia condition will be occur. So because intact RAS system is okay. So and metabolic acidosis may occur, no hyperpigmentation, because there is ACTH secretion is low, mean MSH is also low, so you do not see the hyperpigmentation. So in primary condition ACTH is high, in secondary condition ACTH is low, as the renin we see. It means insufficiency. Secondary mean in the stimulatory system, ACTH is low in the secondary and tertiary, because we are discussing the adrenal, the insufficiency, mean insufficiency in the ACTH in the secondary problem. In the primary, ACTH is also high because due to feedback. So for easier way to differentiate the primary, secondary, in primary you can say PP follow. P pigmentation you can see, in the secondary you do not see the pigmentation. Okay, so second is safe, and tertiary due to treatment or exogenous use. We mentioned the exogenous use. So easier way to differentiate. Primary cause is the pigmentation. You will find the pigmentation. In secondary, your skin is appear no pigmentation. In tertiary, due to treatment, exogenous use. Okay. So these are mnemonic actually help you. So acute adrenal insufficiency and the chronic one. These are actually types of your primary one. So in acute, the adrenal crisis mean where these the function are not gain. So they are stress problem. So such kind of patient. So acute stress due to requirement infection problem in the patient with the pre-existing adrenal insufficiency or the may present with the acute abdominal nausea, vomiting, the altered mental status and shock due to blood pressure problem, and these conditions due to your metabolism system is disturbed, and so acute abdomen, the nausea and vomiting will occur. So in chronic condition, adrenal atrophy mean their completely destruction has been occurred, and autoimmune adrenalitis. So all three zone function has been disturbed. So and result from autoimmune production and tuberculosis can be caused. We are already in the developing countries, while in other countries the cause is the autoimmune disorder. So another really important point is the Waterhouse Friderichsen syndrome. This is actually the blood vessel problem. So bilateral adrenal hemorrhage occur, and it's septicemia. Septicemia means blood poisoning. So because usually Neisseria or the meningitis. So these can be caused DAC, endotoxic shock or meningitis. So the blood due to blood poisoning. So this condition can occur. So may present with the acute adrenal insufficiency. So these are all the part of the insufficiency. You will see it later. So here is actually summary of the primary and the secondary. In primary, adrenal dysfunction; in the secondary, hypothalamic pituitary dysfunction. in the primary you see the mineralocorticoid is defected, but in the secondary no mineralocorticoid defected because the RAS system is okay. So and a high potassium and salt craving, so these conditions could be found. So these are a toxin, infection, or death of loved one person. So all these are stress for this, but they cannot regulate this stress, manage this because of insufficiency of secretion. So in addition crisis, so you know better, cortisol is defected, aldosterone is defected. Oh, okay, so kidney dysfunction or heart problem, so low blood pressure which lead to shock and brain comedy. So in cortisol, liver function disorder, stomach, digestive enzyme decrease, lower sugar, vomiting, diarrhea, cramp. So these all will lead to low blood volume and eventually coma death. So cortisol, glucocorticoid also are the life-saving. We consider this glucocorticoid life-saving in that. So add this point into aldosterone and the parathormone. Also glucocorticoid also are the life-saving hormone. So in concern of the insufficiency of enzyme synthesis, so they may problem. So this one, just recall that 21, 17, 11 also we have covered just fast quickly. So if this hormone is stopped, mean our pathway go to the androgen pathway. So these secretion will increase. So when androgen increase, mean what will happen? Androgen mean the function of androgen will high. So in female their virilization type and masculinization type mean their female body look become male like. Clitoris become penis like, labia become the testes like. So such kind of condition can occur. So and their the early pubic hair development. So because of high androgen. So it's a congenital, mean birth by birth problem. So if this enzyme is deficient. So if this is deficient, so you know better when this is deficient, our mineralocorticoid activity continues because of DAC is present. So these all hormone can perform the job. So in this case, no mineralocorticoid is present, so may lead to death. But in this case, so your mineralocorticoid activity could be continued. And other, if you look at this, if you stop this pathway, mean you no more cortisol, this step stop. So this layer also hormone synthesis stop, and your aldosterone synthesis increase, but you do not see edema because of aldosterone escape system. So which will stop the edema problem. Okay. So there is also same thing is mentioned. So different drugs are mentioned. You can read it. Also we have covered this part. So in 17-alpha hydroxylase, where mineralocorticoid increase because all two layers are stopped. So high blood pressure, hypokalemia condition, and cortisol are low, and other hormones go low, and labs are androstenedione, and your ambiguous genitalia because no more androgen for the female especially. So ambiguous genitalia, lack of secondary sexual character. So in case of the 21, means your androgen are going up, but mineralocorticoid and glucocorticoid both go down. Cortisol and the mineralocorticoid both go down. So blood pressure also go down, and hyperkalemia condition and the other hormone which are the androgen one, so they go up. So in this case, so virilization type of condition you will find so present in infancy, salt wasting, childhood. So for the 11 beta, your DAC is okay, mineralocorticoid activity continue, so your blood pressure go up normal. So but aldosterone are not synthesizing. So your other cortisol go down because cortisol synthesis is not occurring, aldosterone synthesis is not occurring, but DAC is present which performing the mineralocorticoid activity. Renin activity go down. because this is actually the control system. So present in infancy and virilization type also occur in this condition. So all these are actually your congenital and hyperpigmentation due to high MSH secretion when there is high ACTH. Okay, so ACTH also stimulate MSH. So this is actually talk about the adrenal cortex. So we stop it here and later we start the adrenal medulla.